Afternoon, everyone, and a warm welcome to today's webinar organized by ONUS Robotic Hospitals. We are delighted to have you join us for an insightful session that brings together two important health topics that affect many lives. Our first session, Diabetic Foot Treatment, will be led by Dr. Rajasekhar Pappuu, robotic orthopedic surgeon, who will guide us through prevention strategies and advanced treatments that help protect mobility and improve quality of life for people with diabetes. In the second session, Piles to Smiles, Modern Solutions to Hemorrhoids, Dr. Dr. Raghuteja Padma will share safe, painless, and effective treatment options that can truly transform patient outcomes. We encourage all participants to stay engaged, take notes, and share your questions in the Q&A box, and as both doctors will be addressing them during the discussion segment. Once again, thank you for joining us. Let's begin this journey of learning together. Over to you first, speaker, Dr. Rajasekhar Pappuu. Take it forward, sir.
Yeah, thank you. Thank you, Ajay Garu. Okay. So good afternoon, everybody. So today's topic is diabetic foot. What is actually a diabetic foot? Why it is so important in our lives? So most of us will be affected by this disease at one point of our life because the diabetes is in an increasing trend with the changing lifestyle, diet and all that. So there is a every chance that everybody can be affected with this diabetic foot, and the chances of reinfection with diabetic foot is very high. So in 2005, the International Diabetes Federation has realized the importance of diabetic foot as a disease. So they have come up with a slogan that put feet first. Why put feet first? It's because most of those patients who had diabetic foot infections are prone for amputations. Either they go for toe amputation or ray amputation or partial foot amputation or amputation at the level of Symes level or Champapet level or below knee amputation. And sometimes that even might progress to the higher level. So not only foot, sometimes they might lose whole limb also. So that's the reason why they have recognized it as a problem in all the diabetic foot patients. And this diabetic foot amputations are the second most commonly done amputations after traumatic amputations. So the economic burden on any country is very high while treating these patients. Most of the times patients are financially debilitated because of the diabetic foot, because the infections won't come down that easily. And what you see outside is it is only a tip of the iceberg, but the infection might spread very deep into the tissue planes, might affect one compartment to the another compartment, or it might affect only one compartment. And this leads to the complications of the diabetic foot. So what are the complications of actually a diabetic foot? They're diabetic, peripheral neuropathy, peripheral vascular disease, and diabetic foot ulcers. So they might start in any order. Maybe first you might develop diabetic peripheral neuropathy, or you might develop first as peripheral vascular disease leading to your disease, or diabetic foot ulcers. Maybe sometimes you might not have observed this, because most of the patients with diabetes do have around 30% to 50% people have diabetic neuropathy. Is it related to sugars? We don't know, because many people who have high sugars do not have diabetic neuropathy. Many patients who are having average control are also having diabetic neuropathy. So we cannot predict in these patients how sugars affect your nerves. So it's always better to have a tight control of your sugars. So, and then in diabetic patients, you always prone for peripheral vascular disease, that is like atherosclerosis, that causes blockages in the vessels, leading to the reduced blood supply to the foot and lower limb. So these blockages can be at any level. You cannot expect where it is. Sometimes it might be in the abdominal level. Sometimes it can be in the pelvic level. sometimes maybe only in the popliteal artery and below that. So wherever it is, that blood supply will be reduced to the whole limb. That will cause hypoxia in the limb, leading to the infection and harboring of the bacteria there also. So diabetic foot ulcers. What is the reason for diabetic foot ulcer? So diabetic foot ulcer, what we see today is not the initial thing. Maybe you might see as a plantar callus. So there may be some pressures were not equally distributed along the foot while you walk, because these people usually develop during the course of time diabetic foot deformities. So these deformities might cause unequal pressures on the foot. Maybe you might have be having hallux valgus, or maybe some joint stiffness. Sometimes people will have hammer toes, crooked toes, all that. Sometimes you might have calcaneal feet, where you will have more pressure on the calcaneus and less pressure on the toes. Sometimes these people will lose the function of the muscles, because there will be loss of function of posterior tibial tendon. This posterior tibial tendon insufficiency leads to the flat foot. That will lead to the increased pressures on the medial side of the foot, and sometimes that might even lead to the rocker bottom foot. This rocker bottom foot causes pressures over the mid tarsal area, leading to the calluses. So these patients will have some always unequal pressures. And second thing is, important thing is that these people wear always tight shoes, because of neuropathy, they don't know what size actually they are using. That the shoe, whether it fits to them or not, they do not know. So when they buy shoes, they go and buy something which is very tight for them, with already existing deformities in the toes. They don't know whether the size, they have taken a tight shoe that will cause unequal pressures on the shoe, and then skin and all that, and causes calluses. These calluses will slowly lead to the ulceration and then opening of the skin. So these ulcers might be superficial or might be deep up to the bone sometimes, or infection might spread through this. The other problem with these patients is that they do not have sensation, so they don't feel pain. So they feel that everything is fine. They are happy, they are doing very good. So these infections spread and these ulcers won't heal because they don't take proper care. They are not put in a sterile dressing. These pressure sores are not relieved by pressure by changing the shoes. So it is always better to buy better shoe by going free shoe. So otherwise, if you take a tight toe box shoe, that will cause pressures and cause ulcers. So elevated, these deformities cause elevated foot pressures, deformities and all that. So these causes because of neuropathy and also trauma. Sometimes common trauma might add to the ulcers. So most common of cause is trauma only, because these patients do not have sensation, so they don't know that they have injured their feet. So because of that, a wound is developed, and that wound is not taken proper care. That will lead to a chronic ulcer. So with neuropathy, they don't have sensation, and that will also put unequal pressures. So because of that, they start developing secondary deformities. So there are two things. One thing is ulcers because of deformity, and deformities because of ulcers and damage to the tendons and muscles. So these all will add in these patients. So they do not know what is happening actually. So diabetic foot ulceration is the most highly complicated thing, where they think that they do not heal properly. So though it is preventable, it is actually given less importance by the patient itself. Many patient neglects to take care of the foot. So what is the reason for it? There is adequate arterial inflow. So for the wound to heal properly, you have to see that there is adequate arterial inflow to the foot. Then the infection is aggressively managed, and the all pressure is removed from the pressure areas, pressure sore areas. So you have to give for total contact casting, or you have to give diabetic footwear which relieves pressures. Diagnosis of diabetic foot. How do you diagnose? We diagnose with X-ray. X-ray is part of our treatment, though it is not always compulsory to do an X-ray, but X-ray is compulsory. It helps in identifying underlying bone disease. When there is a osteomyelitis of the bone, you cannot just by doing debridement, it won't get cured, or you cannot give the infection, cannot be cleared. So there is an osteomyelitis. you have to compulsorily do bone resection, remove the bone, or you have to go for amputation. If there is no bone, if there is no skin infection, skin is survey, you can just remove this um, uh, bone and leave it like that, so that they will have a shape of the foot. Toes will be preserved, but they will sometimes what happens, they will have develop secondary deformities because of this osteomyelitis. Another complication is that charcut foot they might develop because of this. So X-ray will help in identifying whether the patient is in developing charcut foot or it is only osteomyelitis. Charcut foot also starts initially like cellulitis only, and we always get confused with cellulitis, charcut foot. They will have redness of the skin, then they will have increased pulsations in the foot. The bone is absolutely look normal in the early stages, but there is always some we have to be careful in identifying these patients. Neuropathy, loss of sensation is another thing where they put almost heavy load on that, and that will lead to the osteoporosis because of increased blood supply in the regional bones, that will cause osteoporosis surrounding the joint, and that will lead to the destruction of the bone, painless destruction. Patient will be walking with deformed foot. They will never complain to you that they have some pain or infection or anything. Another thing in identifying these diabetic foot is that angiogram compulsorily, because most of the times when we do a Doppler study, a Doppler is always a technician dependent. We have to rely on the technician, whether it is or a radiologist. We don't know whether they have done it properly or not, because these patients will have mostly swelling. Sometimes infection will be there where you cannot do Doppler of complete. Total length of the artery you cannot see. So if there is a circulation at the proximal level, doesn't mean that you have a circulation at the distal level also. So it is always better to do a angiogram, CT angiogram, simple procedure in which is done in OPD basis. So that will give us where there is blood supply, up to which level there is blood supply. If there is no blood supply, what can be done, how it can be handled, we can decide whether it requires stenting, or if it is single small area of atherosclerosis, you can do stunting and then revascularize the limb. But in most of these diabetic patients, you will have diffuse atherosclerosis, which is very difficult to treat, and you have to put a long lengthy stunt. Even after you put a long lengthy stunt also, there are chances of revascularizing of limb is very less, because they will have problem not only microcirculation is also affected, collateral blood supply is also affected. One single artery feeding does not mean that there is a supply to the collateral supply is there. So it is clearly visible on the angiogram. In this angiogram which I have presented here, see there are only two arteries, so you don't see any collaterals, and then there is only supply up to the middle third of the leg. So this patient is a candidate for Yaboni amputation, because for in such type of patients it is very difficult to manage them conservatively. Even if they we have to immediately counsel them for amputation, because any infection, continuous infection will only cause debility, deterioration of the patient, and then by the time they decide for amputation, patient might be in a very high risk situation leading to comorbidity after amputation. So amputation is associated with high comorbidity. Many patients die after amputation because losing a limb is not psychologically accepted by many patients. So you have to prepare them initially only, instead of giving them hope that your limb won't be amputated, we will save the limb, all that. So we have to see and take a calculated approach to these patients with loss of blood supply. So what we can do as an orthopedic surgeon in diabetic foots patients. So if you don't have blood supply, so vascular surgeon says it cannot be revascularized and it is very difficult to revascularize. So as an orthopedic surgeon, we can do a procedure called um, transverse tibial cortex distraction, which will definitely improve the blood supply to the limb. It increases the blood supply by 90%. So this will definitely restrict your amputation level. Suppose if you are having an amputation at the distal toes, sometimes if there is no blood supply from the popliteal artery, this will definitely revascularize the limb, and you might restrict your amputation to the only foot or toe level amputation. So this will increase your blood supply by 300% than normal supply. So that will help in healing the wound. So these are the few cases managed at our center, Diasol. This is a patient came with diabetic foot. He is in a very debilitating condition. He is having the problem with these all diabetic patients in diabetic foot is it is not only they don't have blood supply in the lower limbs, but blood supply to the other parts of the body like heart is also in a very precarious condition. They might be having blocks up to 90%, 99%. They might be surviving just because they are lucky enough to survive, and they are like always walking bombs. We don't know when they get exploded. So in this case we did tibial cortex distraction and we saved his limb. His ejection fraction was also 30. We have taken on table collapse consent because there is no other way, because patients wants to either he wants to die or he doesn't want to lose the limb. So attenders also were not left with any other option because he is not agreeing for the CABG also, because we gave an option to get the CABG done. But the cardiothoracic surgeon says when there is a lot of infection in the leg, there is high risk of infection post CABG and mortality is very high. So at last we have taken consent from them that we have taken a very high risk consent and we did taking risk this job, and he was saved. He is walking independently after surgery, and he did not get CABG done. He is still surviving. It's for 3 years post surgery. There is no recurrence in this patient. That's the greatest thing. Usually, within 1 year, there is 50% of the patient comes back to you with recurrence of the infection, even after you give 100% clearance of the infection. So another complication of diabetes is diabetic foot deformities. So diabetic foot deformities are very debilitating because you take treatment, spend lakhs of rupees, maybe you might have spent 50 lakhs, 60 lakhs, but at the end of the day, you don't have infection, your leg is fine, but you are still bedridden because the deformity of the foot is not allowing you to walk. So this is another patient where she had taken treatment for diabetic foot. She even underwent at another place by another surgeon for 4 foot amputation. She has undergone partial resection of fourth and fifth ray, total resection of first, second, third ray. She had infection up to the mid leg. So she had undergone total skin grafting from mid leg to the whole dorsum of the foot is grafted for her. She is not able to walk. So we have applied Ilizaro for this patient and corrected the deformity. After the deformity correction, we told them to walk, to take physiotherapy, but she did not take physiotherapy. Now there is recurrence of around 10 to 15 degrees recurrence of equinus. So she is coming for another surgery because of the old infection. She had loss of some muscles also. So because of that, there is some problem, but now we will be correcting it totally. So this is the full correction. She achieved full correction and she will be able to walk. This is another case of diabetic foot where he is having very high sugars, uncontrolled diabetes 500 to 600. His sugars will be, he will be in the hypoglycemic 4 o'clock in the AM, 4 a.m. in the morning, and then he will be hyperglycemic 10 p.m. So it is very difficult. Thinking that his sugars are low, you reduce a little bit of insulin, it goes to, it shoots up to 600. Thinking that he is having hyperglycemia, you give him 4 units of extra insulin, he'll go to hypoglycemia. So it's a very big headache case. He is having diabetes from the past 25 years. He also had a fracture of tibia on the one leg. The other leg is having this is left leg where he had a great toe infection and all that. So we have done tibial cortex distraction. His toe is saved now from amputation. It was almost blackened. So this is the same patient, another leg. This is right leg. He had fracture some 25 years ago. They treated it at that time. It did not unite. Fracture did not unite. After that, he developed shortening also. Limb is short, around 5 to 6 centimeter or 7 centimeter short. So we have done it is in the first stage we have done lengthening of the limb, and then second stage we tried to correct the foot deformity. Is equinus is totally fully equinus. It is straight limb. Actually, foot is totally 90 degrees equinus. It is there. He is having, and then we have taken him for surgery, but because of his diabetics, he developed diabetic nephropathy with salt losing nephropathy. So he had multiple admissions. So at one point I had to abandon all the procedures. There was a gap of 1 year. Deformity correction was not complete, incomplete. But still, after 1 year, after a betterment of his health, they came back to me again for final correction. We have corrected his full correction, and now he is walking. His limb length is also corrected. So now he doesn't have any admissions. So he's walking very well independently. He is around 68 years. He also doesn't want amputation. After 28 years, he got relief from these diabetic foot problems, related foot problems. So they have spent around more than 1 crore rupees for his treatment. So this is what we can do with diabetes foot management. We don't promise you that we'll be saving your limb totally. We will not be doing amputation, no amputation, avoid amputation. We can say that we'll save your limb, limit the amputation, because by the time you come to us, you'll be coming to us in the end stage. If you have come to us like this man, last person who has come initially to us, we could save his limb, but by the time you come to us, it will be already late, and sometimes we'll be in a position where we can't save your partial part limb or part of the great toes or foot completely. So we will be doing basing on the your condition. We'll be treating you and give you the best results. We'll make you walk. We'll see that your infection is completely under control. Thank you.
Thank you, Dr. Rajasekhar, for such an interesting and enlightening session. Okay, I'd like to pose a couple of questions to Dr. Rajasekhar Pappuu. Doctor, when should a patient consider advanced treatments or surgery for diabetic foot?
See, the problem is that advanced treatments can be considered only in the early stages of the disease, because before whatever you do, you have to do it before gangrene steps in. So once there is gangrene, we cannot do anything. So patient should not neglect their disease. So it is better for them to approach early. The other problem is that they themselves do not know that they have some injuries over the foot because they do not have sensation. So it is better to examine feet every day, either before going to bed or after waking up from the bed, and then always maintain chappal shoes to protect those foot inside the house or outside the house. So we cannot say when is the right time, but the earliest the better, because they always come to us late only, because they will be going local doctors. They'll be treating them with antibiotics, dressings, and all that. So diabetic foot is a very complex problem. So it's what you see inside, outside is entirely less than what is there in the inside. So not only that, we have to see whether there are movements in the joints or not. So they also contribute to the ulcer.
Right. Thank you, doctor. I understand that it's very important to regularly screen and for foot
Yeah.
care and and preventing amputations as well.
Yeah.
Doctor, I have another question for you. Can robotic or minimally invasive techniques play a role in diabetic foot treatment?
No, we cannot do with robotic or actually robot is not there for diabetic foot, first thing. Second thing is that minimally invasive, I am totally against minimally invasive while managing diabetic foot. There is a saying in surgeons, there is that the smaller incision, big incision, smaller surgeon, big incision, bigger surgeon, biggest incision. So the more, the bigger you open, You have to go up to the normal tissues where there is no infection also. And keeping the open wound is very big. It is very more important than doing minimally invasive. So minimally invasive has no role at all in managing a infection. Not only diabetic foot, any infection. There is no role for minimally invasive. It is only like eye wash when you do minimally invasive. So don't fall prey to the patient's demands. Tell them bluntly that this cannot be managed in such a fashion. This requires aggressive management. So there is no role for minimally invasive surgeries in diabetic foot or any infection in orthopedics.
True, sir. Especially for the dry man's infection, I
Yeah.
think more exploration is more better.
Yeah, thank you, doctor. Thank you for
Thing is that
answering
when
all
you
those
do
questions.
small incisions, part of the incision infection remains inside.
Correct.
That will be sowing the seeds continuously. So that will lead to the recurrence of the disease.
True, doctor. True. Thank you for the
Thank you.
answers, and quite informative as well.